In ATTR amyloidosis, it's a systemic disorder, and I don't think we appreciate the complete picture of where the deposits actually form. And we don't understand, because of that, exactly what the importance of these deposits outside of the heart and the nerves, maybe the GI tract, they actually play in the patient's sort of journey through the disease, and how the physicians sort of treat these symptoms that are associated, multiple symptoms that are associated with ATTR. It's quite difficult to diagnose because the symptoms are associated with lots of other more common pathologies, and so the patient journey to accurate diagnosis can be quite long. At present, the only definitive diagnosis can be made based on a biopsy of an organ or a tissue, sometimes fat pad biopsy, sometimes endomyocardial biopsy. And those tissues are stained with a dye called Congo red, and you look for this specific blue-green birefringence under the microscope, which is a tough test to do. There's quite a few false negatives associated with that. We've certainly experienced that here. And so what we need, I think, is a non-invasive method that can be used very early on when the physician first suspects amyloid or wants to rule it out, that a scan can be performed, a PET-CT scan that would cover the entire body and be able to detect amyloid in the heart as well as extra cardiac deposits as well. If one can do that, and that's what iodine 124 ATO1 can do, you can start the patient's sort of journey through the disease with an entire picture of where the amyloid is. And because PET is inherently quantitative, for that patient, you can get some idea of how much amyloid might be present in each of the sites that are positive when you see them on the PET-CT scan. So I think it's a really important way to very early on during the patient journey identify that there is amyloid present. So diagnostic, is there amyloid there, yes or no? Provide a full picture of the whole body where the amyloid deposits might be, and also provide sort of a baseline of the amount of amyloid based on the uptake of ATO1 and the quantitation of that uptake as to how much amyloid is present in each of these sites. So then you can follow those parameters across time and see how things are progressing with respect to amyloid load. And so I think it's really important. I think there's a need in TTR patients and many of the other patients. For AL patients, there's really no imaging agent that can look at all the amyloid in all abdominothoracic organs, heart, liver, spleen, kidney. And I think there's a need in all these patients for this type of process.